Hello, everyone. Welcome to our Thursday webinar series. My name is Lourdes, and I am the Director of Patient Services with the Cholangiocarcinoma Foundation. I am glad to have you all here with us today. I'm going to just give it a couple of minutes so that everyone can connect to their audio and listen in correctly. I want to introduce our speakers today. Dr. Daneng Lee is an associate professor in the Department of Medical Oncology and Therapeutics Research and co-director of the Liver Cancer Collaborative at City of Hope in Duarte, California. He holds an MD from Weill Cornell Medical College in New York and continued his training at New York Presbyterian Hospital, Weill Cornell Medical Center, and Memorial Sloan Kettering Cancer Center before joining City of Hope in 2015. And Dr. Mustafa Rauf is an assistant professor in the Division of Surgical Oncology, Department of Surgery at City of Hope in Duarte, California. He received his medical degree from Aga Khan University in Pakistan and continued his training at Yale University, University of Arizona, Harvard Medical School, and MD Anderson Cancer Center before joining City of Hope in 2015. Thank you so much to you both for being here with us today and for presenting on this topic.
Great. Thank you so much, Lourdes, for the kind introduction, and thank you to the Cholangiocarcinoma Foundation for having Dr. Rauf and myself today. So we're going to be discussing this phase 1 trial. That's an investigator-initiated trial that we're doing. That's really exploring pressurized intraperitoneal aerosolized chemotherapy, or PIPAC, for cholangiocarcinoma patients with peritoneal metastases. So in terms of biliary tract cancer, overview, I think many of you on this, webinar today understand that this is really a heterogeneous disease. Biliary tract cancers encompass intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, including parahilar as well as distal bile duct cancers, and certainly gallbladder cancer as well. And what you can see is that, overall survival, despite the improvements of treatments that we have made over the years, is still somewhat dismal. And we can certainly continue to improve upon that, varying from extrahepatic cholangiocarcinomas to intrahepatic cholangiocarcinomas as well. This is still certainly a rare diagnosis. We see typically close to 3% of all adult cancers, so still certainly rare compared to other cancers, but overall incidence is increasing over the years, and I think it's really due to the fact that we're starting to understand the disease better, and really at the initial forefront in terms of pathologic diagnosis, we have improved over the years as well. But unfortunately, majority of patients, approximately 70%, are diagnosed with advanced stage disease due to the fact that this is really a sneaky disease in the sense that many patients are oftentimes having very non-specific symptoms. We really wanted to highlight, something that I think we have seen over the years clinically, and it's that for patients with biliary tract cancers, peritoneal metastases are actually present in anywhere between 10 to 20% of our patients. And certainly both Dr. Rauf and myself have taken care of these patients over the years. And what we know is that particularly for these patients often have very poor quality of life as a result of symptoms from their ascites, abdominal pain, as well as the potential for bowel obstruction as a result of their peritoneal metastases. So, one of the things that we wanted to look at is really, how can we potentially improve the current standard of care that we are doing for patients with advanced biliary tract cancers, and particularly hone in on these patients that have peritoneal metastasis. So this is the phase 3 pivotal TOPAZ-1 clinical trial, which has, certainly improved on our standard of care currently with a combination of gemcitabine and cisplatin plus durvalumab. So to refresh the audience, this was a international multi-center phase 3 trial that enrolled patients that had a histologically confirmed unresectable or advanced or metastatic biliary tract cancer, including cholangiocarcinoma, intrahepatic or extrahepatic, and gallbladder carcinoma. All patients had excellent performance status, and they could not have had prior local regional therapy. And they were then randomized to our prior standard of care with the combination of gemcitabine plus cisplatin every 3 weeks versus gemcitabine plus cisplatin plus ultimately followed by maintenance on durvalumab. And the overall primary endpoint of the study was overall survival, with secondary endpoints being progression-free survival, objective response rates, as well as safety. And treatment ultimately continued until disease progression or unacceptable toxicity effects. And this was the first phase 3 trial to really demonstrate that adding immunotherapy to standard chemotherapy can actually increase survival in patients with biliary tract cancers. So these are the overall survival as well as progression-free survival curves. And what you can see is that there is indeed a statistically significant improvement with the addition of durvalumab, which is a PD-1, PD-L1 immunotherapy agent, plus gemcitabine plus cisplatin versus gemcitabine plus cisplatin followed by placebo. The overall improvement in terms of median overall survival was from 11.5 months up to 12.8 months. And in addition, in terms of progression-free survival, the median progression-free survival for patients that were treated in this multi-center clinical trial with a combination of gemcitabine plus cisplatin followed by placebo maintenance was 5.7 months, and this improved to 7.2 months with the addition of durvalumab along with the combination of gem-cis chemotherapy followed by maintenance durvalumab, and this was also statistically significant as well. However, what is really unknown is that we haven't necessarily seen any type of subgroup analysis in terms of the impact of this treatment combination with gem-cis plus durva on patients with peritoneal metastasis. So this remains relatively unknown. So in addition to this, certainly there was data that was initially presented by Dr. Schroff and her group at MD Anderson at that time that explored a different combination, and now the addition of nab-paclitaxel chemotherapy plus the combination of gemcitabine plus cisplatin. So initially there was a phase 2 trial that was done by Dr. Schroff as well as colleagues at MD Anderson that took 60 patients with advanced biliary tract cancers. And what they saw was that with the addition of nab-paclitaxel chemotherapy, when it was combined with gemcitabine plus cisplatin, it led to a very encouraging median overall survival of 19.2 months and a median progression-free survival of 11.8 months. What was also very intriguing at the time was that the objective response rate, really defined as greater than or more than 30% overall reduction in terms of tumors, was 45% in these patients. So certainly setting a relatively high bar for patients that was treated with this triplet regimen. And overall disease control rates, including those that had a partial response or stable disease, was 84%. So what was also highlighted from this initial phase 2 study was that there were elevated rates of hematologic toxicities that did lead to permanent dose reductions for gemcitabine as well as nab-paclitaxel, of which neutropenia, really lowering your overall infection fighting cells in the body, was the most common grade 3 or higher event at 33%. So this ultimately went on to a SWOG cooperative group trial with SWOG 1815, which was looking at the investigation of gemcitabine plus cisplatin plus nab-paclitaxel now as triplet chemotherapy versus standard care gemcitabine and cisplatin. And unfortunately, as presented at GI ASCO by Dr. Schroff and colleagues, there was no improvement in survival or response rate with the triplet regimen compared to our standard doublet regimen. Median overall survival was 14.0 months with the triplet regimen compared to 12.7 months with the doublet regimen, and median PFS was 8.2 months with the triplet regimen compared to the doublet regimen. And similarly, in terms of objective response rate, so those patients that had somewhat significant responses, the objective response rate was 22% for those patients that received gemcitabine plus cisplatin versus 31% who got the triplet regimen. So while there was a numerical improvement overall, this was not statistically significant as powered by the study. What was also known, and just like the phase 2 trial, was that interestingly there were higher rates of hematologic toxicities in the triplet arm of 60% versus 45%, with common AEs being neutropenia, anemia, as well as low platelets with thrombocytopenia. And there was no significant difference in rate of treatment discontinuation between the triplet and the gemcis arms. Of 24 to 14 or of 19%. So this is really suggesting that maybe there were more potential dose adjustments that was needed in the trial, despite the fact that the trial had preemptively looked at basically ensuring ways to try to prevent potential dose reductions. So, for example, within the trial, there was a requirement to use early use of Neupogen to hopefully counteract the effect of neutropenia to prevent potential dose reductions or dose toxicities requiring either reductions or holding treatment for prolonged periods of time. Therefore, this really suggests that potentially when we add additional agents such as nab-paclitaxel chemotherapy, there really needs to be further optimization of this agent because there is some numerical improvement. It was just not statistically significant. And how do you get to even additional improvement to potentially make this significant in the long term? So this is really where kind of our idea comes on about using PIPAC, and I'll certainly turn this over to Dr. Raouf in just a minute. But the idea is can we potentially improve upon this moving forward, particularly for our patients with peritoneal disease, which we have observed kind of clinically that oftentimes these tumors are even more difficult to penetrate with our standard therapy approaches. So, Dr. Raouf, you want to,
Sure.
talk about PIPAC for us? Yeah.
Yeah, thank you, Dan, for that introduction, and thanks for the organizers for inviting us. So, as a surgeon, I live in the abdominal cavity, treating patients with abdominal cancers, and peritoneal metastases certainly, one of the worst categories of disease because it can cause a lot of problems for patients, as Dr. Lee pointed out. So I think, the idea is that, when systemic therapy is given, for example, nab-paclitaxel, it can have hematologic toxicities, with white blood cell count going low, etc. And so can we give this therapy in the abdominal cavity with limited systemic exposure, thereby perhaps reducing toxicity, and by directly giving it in the abdominal cavity, exposing the tumors to a higher drug concentration, and allowing the tumors to be more affected by the chemotherapy. So that's the central idea. So PIPAC is this aerosol chemotherapy technology. It was pioneered in Germany almost about 10 years ago. It's taken its time to get to the US. There's been a lot of early phase clinical studies done, but not one that has been dedicated to cholangiocarcinoma or biliary tract cancer. So we're really excited about this trial. So the therapy is given laparoscopically. The patients go to the operating room. They're under anesthesia, and we put in small incisions in the abdomen and introduce these trocars in the abdomen. And just like we would do for any laparoscopy, and we assess the abdomen, take a better understanding of where the cancer spread is. Peritoneal disease is notorious because you cannot image it properly with CT scans. So patients can have disease flat or kind of like cotton candy, and it doesn't show up very well. But when you look at it with laparoscopy, you can see the disease better. So it allows us to get a good assessment of disease. And then, once we're done with the biopsies, we do this aerosol chemotherapy. Think of it like fumigating the abdomen with chemotherapy. You do that for 30 minutes, and then after that, the patients go home the same day or the next day. So it is repeatable. And so next slide. Okay, so it is minimally invasive, as I said. It's ambulatory surgery. It's repeatable in 64% of patients in advanced settings. And so far, what we've learned is at least in the earlier first line setting, it's repeatable in almost everybody. And as I said, high dose therapy is delivered directly to the most threatening tumors. There's preclinical studies that show that chemotherapy gets into the tumor better. because we're not subjecting patients to major surgery, the recovery is faster. They can continue and get back on systemic therapy, which is what is required. We need a bi-directional approach, both IV chemotherapy and intraperitoneal chemotherapy. And so early studies from Europe demonstrated encouraging responses, as you can see here, in different types of cancers. Um, it comes with a caveat because the goalposts or the clinical response criteria are challenging. It's not the same as you would on a radiographic imaging. So there's some heterogeneities. There's some variation in how success is defined. So these numbers may seem exaggerated because these are based on surgeon's assessment of the disease. So next slide. Sorry, trigger warning. I should have said that. This is pig intestine, so it's pig experiment, kind of an early proof of concept experiment. People may have heard of PIPAC or giving hot chemotherapy or lavage chemotherapy in the abdomen, which is a conventional way of doing regional therapy. And on the left two pictures, you see that after you just inject a liter or two of fluid with this methylene blue dye, and you take it out, the deposition is not as robust, but where the first generation of PIPAC device was used, you can see there's more deposit. It's not perfect when this was first published in 2012, but you can see that there's definitely more chemotherapy deposited on the tissues. So next slide. So this is kind of a collage of pictures demonstrating the actual procedure. So, the setup at the time of surgery, a surgeon standing there, you can see the camera is positioned and held, and the big white arrow is pointing to the aerosolizer, the nebulizer. It goes through a laparoscopic port. We take biopsies of the tumors. You can see how the peritoneal disease is kind of flat, and you can also imagine how that would be hard to see on CT scans. And we use balloon trocars so the chemo doesn't leak out in the operating room, and there's a lot of safety measures in place for the operating staff and the patient. So next slide. So everybody leaves the operating room actually during the aerosol procedure. You can see our anesthesiologist standing in the hallway with across the window, and there's all remote monitoring. So there's a IV line and everything that goes in the other room. So patients can still be managed, but the team is distant from the patient, and the patient's protected because they're on the ventilator with the breathing tube, so that they don't actually inhale any chemotherapy. So chemo is only given in the abdomen. So next slide. And then this is how it looks like. You can see the nebulizer spraying the chemotherapy in the abdomen. So that's what fumigates the abdomen. And in the distance, you can see those white spots. Those are cancer spots kind of on the intestine, on the inner lining of the abdomen. So next slide. So earlier studies, phase 1 studies, have tried to figure out what regimens are optimal in different cancer types. You can see ovarian, gastric, colorectal, small bowel. There's a small study on the very bottom on hepatobiliary and pancreatic cancers. There's not many cholangio patients in that study. But nonetheless, the drug that we're using, nab-paclitaxel, is listed. And these studies have demonstrated what the optimal dose or recommended phase 2 dose is. And so that's been a big addition to the armamentarium and for us to design our clinical trial. So next slide. So we started our endeavor in year 2020. Our first patient we treated was in August 2020. And this was the initial clinical trial design. It was based on the type of chemotherapy. We wanted to recreate the experience in Europe and kind of assess it independently. And so these are patients with refractory ovarian, gastric, colorectal, or appendiceal cancer. This is a collaboration between 3 sites. So City of Hope, Northwell Health, and Mayo Clinic. And essentially in this study, patients were given single agent PIPAC, every 6 weeks. There was some IV 5-FU or some systemic therapy, very low sensitizing dose that was given for second and third PIPAC. And we evaluated toxicity. The goal was to determine safety of this regimen. And so arm 2 is accrual is complete. Arm 1 is in expansion phase. The initial part has completed accrual. So I'll share some data for the arm 2. So next slide. So arm 2 was refractory colorectal appendiceal cancer patients. We enrolled 12 patients, and these patients were pretty typical for what we see for colorectal and appendiceal cancer, but they had progressed on all lines of chemotherapy. And what you can see here is the feasibility. 50% of patients completed 3 cycles, and the number one reason they couldn't complete therapy was because they had progressed by the time of second PIPAC. So I would say, so you'll see the data, but about half the patients would have progression. And importantly, we did not see any surgical complications or any dose-limiting toxicities at the dose level we tested. So next slide. Next slide. So this is some of the efficacy data. It's too early to conclude, whether this regimen is effective. What we're looking for is there an efficacy signal with this regimen? And so one of the goals of some of these therapies is to see if patients can get to surgery. And so in our cohort, these are patients who were not surgical candidates. So when after therapy, 2 out of the 12 ended up getting complete cytoreduction and hyperthermic therapy. Half the patients had stable disease, half the patients had progressive disease by radiographic criteria. We also assessed the disease by laparoscopy. So similarly, half the patients had a decrease in their peritoneal burden, and half the patients had progression or only had 1 PIPAC because of progressive disease. And same way, histologically, 42% of the patients had decrease or decrease in their PRGS score, which essentially means that they had response on the biopsies. And you can then see the swimmer's plot. So each line is the patient's journey over the months followed. And you can see how the patients did. Some patients on the top did actually pretty well, whereas those on the bottom did not do so well. So next slide. So yeah, this is the first study that demonstrated the feasibility and safety of performing PIPAC in the United States in a multi-center setting. So next slide. So one of the important things here is that, we know in that advanced setting, the therapy is not curative. So does it actually matter to patients? Are they home and are they alive rather than being in the hospital? So that's an outcome called good days. It has been used in studies because it's an objective way. You're either in the hospital or you're not. You've either died or not. So we can actually measure it reliably. And so we went through our historic patients who had been treated with systemic therapy. And these are the patients who would have been candidates for the PIPAC trial, but were not enrolled because maybe they had too many adhesions in the abdomen, or they opted for other clinical trials. So when we compare those patients to our PIPAC cohort, we see that they at 6 months and at 1 year, we had significantly better number of good days, average number of good days for these patients. And the swimmer's plot, or the journey of patients through the treatment, is shown with ST as the standard therapy and PIPAC as the PIPAC cohort. So next slide. When we look at the overall survival now, we're comparing apples and oranges. These are not patients that are randomized, so this is only hypothesis generating. But what we do see is that receipt of PIPAC was associated with better survival and numerically better progression-free survival, although that was not significant. And so what these results tell us is that there is a potential efficacy signal, and the treatment is safe in a refractory colorectal appendiceal cancer patient population. So next slide. Okay, next slide. So because only 50% of patients had some response or stability, we wanted to see if we can move this earlier in colorectal and appendiceal cancer. And this is the first time we introduced bidirectional therapy. So we said we wanted to treat patients both with IV systemic therapy and giving therapy in the abdomen. And so for this study, we chose an agent called mitomycin C. So mitomycin C is an agent that damages the DNA of the tumor cells. It has a long record of regional therapy, and there's a lot of safety studies that have been done on it. So this seemed to be the obvious choice because of some efficacy signals in previous studies, although not with PIPAC. This is the first PIPAC study with this agent. So the first goal was to establish what the appropriate dose is. And so this phase 1 study was launched now almost a year and a half ago, and it has 4 dose levels. And so essentially the way we sandwich this is that patients who have had first-line therapy, for example, for colorectal appendiceals, FOLFOX, which is also used in cholangiocarcinoma sometimes. So after 4 months of chemotherapy, they're evaluated. If they're not candidates for surgery, they get enrolled onto this trial. They should not have any metastases outside the peritoneal cavity. And what we do is um, uh, we enroll these patients on the trial, and at the listed dose level, and it's a dose escalation design, so they get the mitomycin C dose, and then 2 weeks following that, they get the IV systemic chemotherapy. So in this case, FOLFIRI, which is different from their first line treatment. So they will get 2 cycles of FOLFIRI, then they get PIPAC, then 2 cycles of FOLFIRI, then PIPAC, and again, the 2 cycles of FOLFIRI. And there's an optional laparoscopy to assess if they would be candidates for surgery. And primary outcome was to determine the safety, and be monitored for dose limiting toxicities and other adverse events. There's a lot of translational studies. Every time we take biopsies, we study the cancer and evolution. So this is a big emphasis for us to understand the biology of cancer and improve therapy. So again, we partner with all of our sites in a multi-center fashion. So next slide. So far, interim results, we've presented these at SSO and ACT meeting. 13 patients were enrolled at the time of this analysis in March, and the different variables are listed. These are high burden of cancer patients. So PCI at 27, 39 is maximum, 0 is nothing. And so typically we're operating on patients with PCI of less than 15. So these are patients who are high cancer burden. When we've treated these patients in this way, we have not seen any dose limiting toxicities at the time of this analysis up to the first 2 dose levels. There were no surgical complications. One patient after their second PIPAC had an ileus that was somewhat severe, lasted 2 to 3 weeks, and then it resolved, and the patient actually had a really good response to therapy and has been off therapy for almost 2 years now. And so what we've noticed in this analysis that there's that one patient had ileus and abdominal pain, but otherwise toxicities are uncommon. To compare to systemic therapy, usually you will see up to 15 to 20% of patients will have grade 3 adverse events. So this is very well tolerated. So next slide. Does it work? So we look at different criteria for response. So PCI is the laparoscopic response criteria. PRGS is the histologic response criteria. And so basically, when we look at it with laparoscopy, we see reduction in cancer burden by the PCI score. And then for PRGS, based on histologic criteria, there is reduction in score, meaning on average, we're seeing responses from PIPAC 1 to PIPAC 3. Next slide. Objectively, we measure CEA level, which is a tumor marker in the blood, and we see almost all patients have a response in their tumor marker. And as I mentioned, the peritoneal disease is very hard to measure radiographically. That's the RECIST criteria. And so essentially, most patients have no changes, either stable disease or non-measurable disease. Nobody has had progression of disease on the analysis so far. One patient had a complete response and one patient had a partial response. So next slide. So in summary, these studies indicate that this is a very promising approach. And so I'll pass it to Dr. Lee to discuss this study, which is the nab-paclitaxel study with PIPAC.
Sure. Thanks so much, Dr. Rolf. So this was a PIPAC study with nab-paclitaxel, which was a phase 1 dose escalation study. So this was a study that was done by, I believe, our your European colleagues, and it took 23 patients with gastrointestinal, breast, or ovarian cancer with peritoneal metastasis. Up to 3 instances of PIPAC was administered with concurrent chemotherapy in 13 patients. And what we're seeing was that there was a histologic response of 35%, stable disease of 35%, and a 1-year survival of 57%. So this really demonstrates that, potentially using nab-paclitaxel with PIPAC through PIPAC was safe and tolerable, and that there was preliminary activity even among patients who had received a concurrent chemotherapy. So with that in mind, and as well as some of the earlier studies that was done in the US through the PIPAC collaborative that Dr. Rao shared and everything, as well as, our feeling of, why are we doing this for our patients with biliary tract cancers? It's the fact that, I can't tell you how many patients that we've treated for patients that have peritoneal metastases from biliary tract cancers that their quality of life is absolutely miserable. And we really wanted to, change that. And with our current standard of care treatments, sometimes we just see that even if there is disease that's improving in other areas with our systemic treatment, the peritoneum oftentimes, for whatever reason, tends to be fairly resistant to that treatment, and our patients are not feeling better with the treatment, even if other areas are necessarily improving. So this is why we wanted to do this study in our biliary tract cancer patients with peritoneal metastasis. So the primary goal of our study was to really evaluate the safety of PIPAC nab-paclitaxel in combination with systemic chemotherapy, gemcitabine plus cisplatin, plus immunotherapy with durvalumab, based off of data from the TOPAZ-1 phase 3 trial in patients with biliary tract cancer and peritoneal metastasis. The secondary objective is really to evaluate the preliminary efficacy of this regimen of PIPAC nab-paclitaxel plus gemcis plus durva. An exploratory manner, as Dr. Rauf also showed you on those other PIPAC studies, we're going to be able to follow the trajectory of this disease really for the first time, right? Because we're going to be getting there in terms of exploring the peritoneal metastasis, and we can then, really start to characterize the subclonal evolution as well as the tumor microenvironment changes in response to the treatments that we're delivering, as well as evaluate the therapeutic advantage of PIPAC delivery via PK studies as well. So these are the key inclusion criteria. So any adult age, greater than or equal to 18, along with a good performance status, ECOG of 0 or 1, as well as a histologic or cytologically confirmed diagnosis of intrahepatic cholangiocarcinoma or extrahepatic cholangiocarcinoma or gallbladder cancer can be eligible for this study. They have to have documented metastatic disease on CT imaging or MRI, along with visible peritoneal disease on either cross-sectional imaging or on diagnostic laparoscopy. The reason why we did that is, as Dr. Rauf previously mentioned, sometimes these peritoneal metastases are very difficult to see on imaging criteria, and we didn't necessarily want to exclude patients that cannot be seen in terms of resist measurable disease. So as long as they have evidence of peritoneal disease that we can either see on cross-sectional imaging and meet criteria, or they can be directly visualized through a diagnostic laparoscopy where Dr. Rao puts a camera in the abdomen, then they're eligible for the study. Patients must have fully recovered from any type of acute toxic effects from any type of prior anti-cancer therapy, such as any type of prior surgeries or other therapies that were given before. In terms of exclusions, any prior systemic therapy for current metastatic or locally advanced biliary tract cancer patients are excluded. So, i.e., you couldn't have essentially started, systemic treatment for new metastatic or unresectable or recurrent disease. What is allowed is that patients that previously underwent adjuvant therapy, whether it's radiation therapy, biologic therapy, or even immunotherapy or other chemotherapy, they're only excluded if you essentially received that within 6 months prior to registration. So let's say you had previously completed adjuvant treatment and then ultimately developed, recurrence after adjuvant therapy. As long as there was a 6 months interval, from that, then you are potentially, eligible for this study. There can't necessarily be any other medications in terms of strong CYP3A4 inducers or inhibitors within 14 days prior to day 1 of the protocol therapy. Patients that had bowel obstruction requiring NG2 placement or percutaneous endoscopic gastrostomy, or they're on total peritoneal nutrition are excluded. We did wanted to, really limit this and everything. So patients that have otherwise a significant high burden of extraperitoneal disease, for example, greater than or equal to 50% of liver occupation, then we wanted to, exclude those patients, as well, just because we didn't want to make sure that the extraperitoneal disease was the majority of the burden, since we're really kind of targeting the peritoneal disease. But we also didn't want to necessarily also exclude patients that can, potentially benefit from this treatment, given the fact that they're also getting systemic therapy in addition to the nab-paclitaxel, PIPAC. So if they have, somewhat limited, extraperitoneal disease, whether it's in the liver or other sites, they're still eligible for this clinical trial. They can't have any history of, current brain or subdural metastasis, have estimated life expectancy by the investigator of greater than 3 months, can't have a history of peripheral neuropathy of grade 2 or higher, and a history of allergic reactions to the compounds that we're giving, including platinum-based compounds. So this is the study schema, and I know what's the highlights, here is that the dosing of the gemcitabine on our trial is a little bit modified. I showed you a prior slide of the TOPAZ-1 phase 3 trial, and there was an error on that slide that I apologize for not correcting, because in that trial, the gemcitabine is at 1,000 milligrams per meter squared. In our trial, we're actually using the gemcitabine at 800 milligrams per meter squared. And the reason why we're using that dose was that, since we're adding nab-paclitaxel here, the SWOG phase 3 study used a lower dose of gemcitabine to really, potentially help in terms of, possible hematologic studies. So the gemcitabine dosing is the only dosing that is, different compared to the regular, standard of care in terms of the TOPAZ-1 regimen. But otherwise, the cisplatin dosing is the same at 25 milligrams per meter squared. Durvalumab is given at the same dose of 1,500 milligrams on day 1 of every 3-week cycle. And in terms of the PIPAC, we give the PIPAC on day 3 of cycles 1, 3, and 5. And the PIPAC dosing with nab-paclitaxel is set at 90 milligrams per meter squared initially. So as I showed you on some of the prior, background slides with nab-paclitaxel, we feel that this is a very safe dose, given the fact that, prior studies using nab-paclitaxel had shown that it was, feasible and safe at even 112 milligrams per meter squared. We wanted to be, extra conservative here, given the fact that we're really, in a way pushing the envelope, and this is a quadruplet treatment, right, for the first time, rather than a triplet treatment. So we wanted to make sure that it would be, safe and certainly potentially tolerable for our patients. So this ultimately, the PIPAC nab-paclitaxel is given on cycle 1, 3, and 5, and then the Gemcis Durva is given standardly 2 weeks on, 1 week off, for a total of 8 cycles or 6 months of treatment. And once they complete treatment, they essentially continue to follow the TOPAZ-1 regimen, where they are then continued on single agent durvalumab as monotherapy maintenance every 4 weeks. And really what we're looking at is really, again, safety based off of adverse events, any evidence of, dose-limiting toxicity that's encountered, and also looking for, preliminary efficacy outcomes in terms of progression-free survival as well as overall survival. So these are kind of additional resources that you can certainly go to learn about this trial, whether it's clinicaltrials.gov, NCI, websites, our own City of Hope website. We were able to present a trials in progress abstract at this year's ASCO, detailing about the study that you can see on this link that you can get to as well to learn more about the study. So this study, couldn't be done without, our funders. So this is a purely investigational initiated study. This is not at all funded by industry. So this is really a grassroots effort, so that all of the, patients that enroll in the study while we get insurance authorization for the standard of care, procedures. All other parts of the study are paid for as a result of, the generosity from our philanthropic, partners, whether it's the Phase 1 Foundation, which is a local group here in Los Angeles that, funds studies, particularly early phase studies, nationally, as well as the Cure Cancer Research Group, also here in the Southern California, which, both of these organizations have been, really wonderful in supporting this study, from the very beginning to really help us, challenge the current standard of care in order to improve the outcomes of our patients with biliary tract cancer, particularly our patients with peritoneal metastasis. So with that, I'll end here, and both Dr. Rauf and I will certainly be open to answering any of the questions that you may have.
Thank you so much. Yes, if anyone has any questions, please put them into the chat or the Q&A, and please remember to make your questions general in nature. We have a few that have come through. So you said it was repeatable, the PIPAC. Is it once, twice? What's like the maximum number of times that someone could receive PIPAC? And is it same day outpatient procedure?
Yeah,
Yeah.
so
Go ahead.
Yeah, so PIPAC is repeatable. In the trial we have written for 3 PIPACs. The patients do go home the next day. The only reason they stay in the hospital right now is because one of the things we measure is drug concentrations in the bloodstream, and we do it over 24 hours. But in practice, beyond the clinical trial, there's no reason patients shouldn't be able to go home the same day.
Okay. Can you share the reasons for such a long list of exclusion criteria?
Yeah, so I actually think our exclusion criteria is actually relatively short compared to most clinical trial protocols. We wanted to make sure that it was as open as possible, but at the same time, when we went through our internal disease team, meetings while we're designing the protocol, we certainly wanted to make sure that the patients that we were treating were going to be the patients that were really going to be benefiting as well without, any new safety concerns. So that's the reason why, we somewhat limited upon the amount of extraperitoneal disease that might be, seeing in certain patients, just because, again, this is directly going into the peritoneum, and that's where it's going to have its maximum effect. Now, we have, thought about, hypothesis of where we're doing that can potentially even maybe have somewhat of an immune modulatory component and can actually make our systemic therapies even more powerful. But that's only, purely hypothesis, speculation as well as generation and everything like that. So for this initial iteration of the study, we had to be a little bit more tighter to focus on really being safe, for our patients, and also really helping the patients that are going to really see potential success, from this type of treatment.
Okay. How does an oncologist even know to consider whether a patient has peritoneal metastasis, especially as it doesn't show up on the CT?
That's a
So
great, yeah, go ahead. Yeah.
Yeah. So I think one of the things that happens is, patients are often being considered for surgery when they don't have metastatic disease otherwise. And so at the time of surgery, it's a common practice, actually standard of care, to start with a diagnostic laparoscopy. So the surgeon will place the camera in and inside the abdomen, and then that's when they will notice that there is peritoneal disease, and that's an indication not to proceed with surgery and to go to standard of care systemic therapy. So that's one way people will find out. Sometimes it will show on CT scan, and sometimes it requires an astute oncologist and a radiologist to be able to understand the scan and consider, that there might be peritoneal disease. And certainly, patients are high risk. Up to 30% of patients will have peritoneal disease when they have locally advanced tumors. So I think you have to have that high index of suspicion. And at our center, we definitely look for this pattern so that we have a low threshold to perform a laparoscopy to confirm that there is peritoneal disease, so patients can be enrolled.
Okay. Why did you choose to reduce the dose of gemcitabine versus giving a lower dose of nab-paclitaxel? Are you not compromising the standard of care?
Yeah, no, that's a great question. So again, because of the fact that we're now entering the age with this trial of quadruplet therapy and everything rather than triplet therapy, there is the potential increased risk of additional hematologic toxicity, right? So we looked towards the SWOG protocol, and in the SWOG protocol, they had the same criteria where they reduced the gemcitabine to 800 milligrams per meter squared with the addition of nab-paclitaxel. And what you can see was that while it didn't necessarily have a statistically significant improvement in terms of overall survival, progression-free survival, as well as objective response rate compared to standard doublet, GemCis, it was not inferior, right? But it was actually like a trend in terms of improvement in those key efficacy outcomes. So this was really kind of the balance to follow that in the sense that this is not an inferior approach and everything as demonstrated by the SWOG phase 3 study. And at the same time, because we're now entering quadruplet, treatment, this, potentially help us to really minimize any of the toxicities, from issues that were raised from the SWOG protocol.
Is it possible to put the slide up of the exclusion? There's a couple of questions about having had systemic therapies in the past, and then also if metastasis to other areas is a reason for exclusion. So if you could just maybe put that slide back up.
Hold on, nice. Okay, let me go back. Okay. So what this meant is let me just kind of clarify this a little bit. This is a first line study for patients with essentially locally advanced or unresectable or metastatic biliary tract cancer patients. So given that it's a first line study, what we mean in terms of any prior systemic therapy is that you couldn't have received another first line treatment essentially prior to going on this study. We make the exception of those patients that receive adjuvant treatment in terms of postoperative chemotherapy. So if you ended up, let's say, receiving single agent capecitabine as part of, a bill cap for, resected biliary tract cancer patients, and it's been more than 6 months, prior to, enrollment on this study, then you're certainly eligible for the study. But otherwise, because of the fact that this is really designed as a first line study, you can't have any other, necessarily systemic treatments, for a biliary tract cancer advanced diagnosis.
Okay, and then metastasis to other areas, is that an exclusion factor?
No, it's not an exclusion factor. Like I said, we try to make this as broad as possible. So this, high burden of extraperitoneal disease, there's a criteria in terms of, if you have greater than or equal to 50% of liver occupation, for example, that's really meant to give us an opportunity to, again, really help the patients that we think are going to benefit from this treatment, right? If you are, or if a patient has, let's say, 90% of liver occupation, and then your peritoneal disease is somewhat, small, then it's going to be less likely that you're going to potentially benefit, from this treatment, since the additional regimen that we're really adding here is targeting the peritoneum, right? So patients that have metastatic disease at other sites are not necessarily excluded. It's just that if they have significant extraperitoneal disease burden, such as this, criteria of greater than or equal to 50% liver occupation, then we don't think that you're going to necessarily get maximum benefit here and everything. And therefore, we did not think that it was in the best interest of those types of patients to enroll on this clinical trial.
Perfect, thank you. Can you put up the slide that has the clinical trial numbers, please?
Yes.
And Is there any way to fast track being considered for the PIPAC at City of Hope? I don't
So
know if that means the clinical.
our study is, open to accrual and everything. So, it's all you have to do is, contact, City of Hope and, specifically say like, you're interested in the PIPAC trial and, certainly, myself and, Dr. Raouf would be, happy to see you for consultation. And based off of, preliminary review of your records, if we think that you're a potential, candidate for the study, we can certainly go over the study with you to see whether or not you would like to proceed and potentially sign consent for the study.
Okay. And the only site that this is at City of Hope, correct?
Yeah, this is a single institutional study because again, this is a purely investigator-initiated study. So we really wanted to really do this as the initial determination of safety for this because, like I said, it's the first time that you're going into kind of a four drug regimen, and also the fact that it really to identify the and establish the safety, but then also potentially identify preliminary efficacy. And if we can, really demonstrate potentially those two things, then we would be happy to, expand this further in terms of our, PIPAC, collaborative group, and whether or not, ultimately if there is interest in the larger setting for the cooperative group. I think this will be, somewhat, self-specialized in a way and everything. We understand that this is a very different, trial and everything. But again, this is really based off of the science that we have, right, and everything, in the sense of us, looking at this already in terms of other diseases, as well as, kind of what we've seen clinically, where we feel that this is a tremendous, unmet need. So, for those reasons, in order for us to really kind of provide this, access as quickly as possible, we were able to kind of, really do this through a grassroots effort and, raise all the funding through philanthropy and, philanthropic, foundations.
Perfect, thank you. At the beginning, ascites was mentioned. Does peritoneal metastases cause ascites, or does ascites create an environment where peritoneal metastasis happens?
I think typically there is a little bit of fluid in the abdomen, less than 30 cc's. That's physiologic. So ascites is any fluid in the abdomen. There's a lot of different reasons for ascites, that are not cancer related. But in the setting of peritoneal metastases, usually the metastases are the ones that are thought to create, this fluid in the peritoneal cavity. But that's a great question. I don't know if that has been addressed. If the ascites in the abdomen create a pre-metastatic niche, to actually promote further tumor progression. I think that's a great question. I don't know if we have a full answer to that.
Okay. Is there a concern about PIPAC causing seeding of cancer, for example, along the laparoscopic tract?
We have not seen that. So historically, that is true. So patients who've had surgery, especially laparoscopically for their gallbladder removal, and were incidentally found to have a gallbladder cancer, port site metastases are actually quite common. If and then that also is an extension of peritoneal disease. So the tumor deposits on the inner lining then grow through the port site, and that used to be an issue. So once peritoneal disease is established, the cat's out of the bag at that point. So we don't worry as much about port site metastases. But having said that, I think we have not experienced that with all of the patients that we've treated with PIPAC. Something about delivering chemotherapy may inhibit port site metastases.
Okay. PIPAC focuses primarily in the peritoneal cavity. How do you concurrently attack the intrahepatic cholangiocarcinoma tumors?
Yeah, so as we mentioned, again, this is in addition to standard care treatment with gemcitabine plus durvalumab, right? So the idea is that for the disease outside the peritoneum, you're getting still standard of care treatment that would essentially, tackle that. And like I mentioned, potentially, and this is something that we have to, explore, through our, possible, kind of correlatives, is whether or not is there an effect of, PIPAC, nab-paclitaxel, not only in the peritoneum, but could potentially augment response to our other systemic agents as well. So.
Do the peritoneal metastases need to be small for the trial?
That's it's not an exclusion criteria, but sometimes when the disease burden is advanced, patients will lose a lot of weight and they will have obstruction or dysfunction of their small intestine, or they will have a lot of ascites. And so those are exclusion criteria because that typically indicates a very advanced disease, and unfortunately at that time any intervention is futile. And to subject patients to interventions that are especially requiring anesthesia may not be the best thing. But for the most part, we have not set an exclusion criteria on the actual number or the PCI score. All patients would be evaluated.
Okay. Those are all the questions that we have. If anyone else has any other questions, please send them in now. Otherwise, I want to thank you very much for your time and your explanation of the trial to the community. We appreciate it. Somebody else said one. I think there's just maybe a little bit of a question between HIPIC
Yeah, I
and
think I can address
PIPIC.
that. I think it's a great question. So, I think the question is that HIPAC is not standard for cholangiocarcinoma, and the literature doesn't support it. And certainly, I completely agree with that. I think, the HIPAC is actually given after surgery is done. So you do resection of peritoneal metastases, and then you do the hyperthermic intraperitoneal chemotherapy. So we do that a lot, as standard of care for a lot of different cancers, but we don't do it for cholangiocarcinoma. And as the person who asked the question suggested, the literature does not support it, and that's been our experience also when we've made an exception for a young patient who's done really well. We have been discouraged by the results of that. So this is very different from HIPAC because we're actually not doing cytoreduction. So you have to remember after a big surgery like that, patients take 3 months to recover, 2 to 3 months to recover. They're off of systemic therapy. And during that time, cancer is growing and, a microscopic disease will return. In this situation, the systemic therapy continues. We don't stop systemic therapy. But in addition, we're giving regional therapy without actually doing surgery. So it's a very different approach that we think will be much more promising and because the rationale for giving regional therapy is still there. When you give a therapy in the abdomen or in the peritoneal cavity, it exposes the tumors much more effectively to that chemotherapy rather than giving it through the vein, where less than 1% of the chemo actually gets to the tumors, to the peritoneum. So the approach, the rationale of regional therapy still exists, but we're not without the detriment of a massive operation, which I think is the main limitation.
Thank you. Well, to respect your time, we appreciate you being here and sharing. And if anyone has any questions, I think they had this will be recorded. This has been recorded. It will be up on our YouTube channel, but the clinical trials site information and all of that will also be on that recording. So you can always reference back to that. Thank you again. I hope everyone has a really great afternoon.
Sure.
Thank you.
Thank you. Take care.